All right. Here we go. Secondary assessment. So we're through our skill sheet, right? We've done scene size up. We've done primary assessment. So we've got BSI, is my scene safe? How many patients do I have? What's my MOI? What's my NOI? Do I need additional resources? Does my patient need C-spine stabilization? My general impression is, my patient's chief complaint is, my patient's level of consciousness is my airway open and patent? What's my breathing? Is my patient breathing? Is it inadequate or not adequate? I'm going to give oxygen. What's my patient's pulse? What is their skin CTC? I'm going to control any major bleeding. I'm going to take a full set of vital signs. I'm going to determine if my patient is critical or not critical. Okay? That's just the first two, right? You're halfway down the sheet. Okay? Now your secondary assessment changes between medical patients and trauma patients, right? Some medical patient has a couple of different acronyms. What are you missing? Trauma patients have a different set of acronyms and some priorities. Enjoy. Watch your mouth. So, this is like it's 160 slides. Okay? I will tell you right now, if you fall asleep, you are going to fail your next test. Okay? Pay attention. Every single one of these slides is vitally important. Okay? Make sense? Stay awake. Right? We'll have another break between now and 11 o'clock, but stay awake. Tonight we're going to 11. Just kidding. All right, so components of the secondary assessment. You've got the physical exam. Patient history has two pieces. Every single EMT in this friggin' county forgets there's two pieces. Every single one, right? There's history of present illness, and there's past medical history. I forgot these acronyms on the board. Oops. HPI and PMH. We don't use them very often, but in case you see them. Okay? When you start asking history questions, you want to know what's the history of what's going on right now, and then do you have any other medical histories? Does that make sense? Everyone shake their head while you're writing. Perfect. What's going on now, and have you had anything else? Okay? The textbook is going to ask or tell you to ask open-ended questions. I agree 80% of the time. You can ask the question, do you have any past medical history? And they say no. My rule of thumb is then you ask specifics. You're telling me you're not diabetic, you have no cardiac history, you have no respiratory problems, you have no history of stroke, right? Because those are the ones that for some reason people leave out when you ask, do you have any medical history? Well, yeah, I used to be diabetic, but I take insulin now, so I'm no longer diabetic. That's not the way this works, right?
All of a sudden they've had heart failure?
Yeah. Oh, yeah, I have cardiac history, but I take nitro every single day and aspirin every 48 hours, so my heart attacks are cured. No, right? That's not really the way this works. So two pieces of this. Signs are something you can see, right? That should be self-explanatory. Symptoms is something they tell you. Chest pain is not a sign, okay? Levine's sign is a sign of chest pain. Make sense? Hand clenched over the chest. Okay? Signs something you can see. Symptoms is something that they tell you. And then we're going to talk about reassessment. Okay? It's poor to tell you that you should reassess every 5 minutes for critical patients and reassess every 15 minutes for non-critical patients. Because theoretically, reassessment is always happening. Right? It's like airway. Airway is a continuous process. If you think about it, you're always reassessing something. Does that make sense? Great. Here we go. First two acronyms. We're going to tell you definitions here in a second. All right, history-taking techniques. Ask open-ended questions and use mnemonics. Okay? The two most commonly mnemonics that you'll see a ton is sample and OPQRST. Okay? Why do we use mnemonics? What's the purpose? Save time. For what, though? You don't save these letters when you ask patients questions. So it's easy to remember, right? You use this as a guide for you, not for them. Because if you go, answer me sample, they're going to go, what? right? It's for you to repeat at the top of your head, okay? Anything you can find a way to make an acronym or mnemonic, do it in this class. This is the very best way to jog your memory of stuff, okay? If sample doesn't work for you, then the same letters, if you want to think of a different word, maples, I don't care. I just made it up just now. That was impressive. Thank you. Thank you. Have a wonderful day. You guys can get out of here. Right? I don't know how I just pulled. I can't spell and or the, and I just came up with maples. Yeah, it's amazing. Right? So in testing, I don't care the order. Right? You can say, you can ask the E, the M, the S, the L, the A, the P. I don't care. Right? The order doesn't matter, but you have to ask all of those questions. We're going to tell you the definitions here in a second. You should already know them because you were supposed to read because you thought there was a pop quiz. Right? I don't care how you remember this. The downfall, if you don't use mnemonics like this, you'll say, what's your past medical history? They'll give it to you, and you say, when's the last time you had something to eat? And then you'll say, oh, what are your signs and symptoms, what's going on right now? And now you've already forgotten what you've asked and what they've answered. Right? The purpose of this is do it the exact same way every single time so you never forget it. S-A-M-P-L-E. Right? Or M-A-P-L-E-S. They couldn't even spell maples. Right? I don't care how it works for you. Just figure it out. Fix it the way it works for you. Okay? Here's the other one. My other biggest pet peeve. What is the first word that's in red? Physical. Okay? Which means touch. Stop it. What's the second word? Which means you have to use your eyes. Physical is touch. That's your hands. Ah, Jesus. This is going to be real long. Okay? So there are three things I want you to know. With physical exam, you have to inspect, you have to palpate, and some things you auscultate. Inspect means you use your eyes. Palpate means you use your hands. Auscultate means you use a stethoscope. Okay? With physical exam, you have to do all three of them. Okay? Can you inspect somebody adequately in trauma with their clothes still on? No. That's why EMTs get called scissor sissies, right? Because we break out scissors, we cut your clothes off. Get arrested. Right? You will hear us use terms, not other evaluators. Other evaluators are horrible, horrible people. I never say mean things like strip them and flip them, right? Which we use all the time, right? Trauma patient's a naked patient. They're a term we use. You'll hear those two terms all the time, right? I'm a big fan of keeping a patient's dignity up until the point where your life is in danger. I don't care what clothes you're wearing. I don't care what I think you look like under your clothes. They're coming off, right? Because I can't do my job unless I can see the injury, okay? There's always people who are like, okay, so what if there's this car wreck and there's this, like, girl that works at Hooters and now she's driving her car and she wrecks her car. Are you going to cut her clothes off? Absolutely, right? If you act like you're doing something wrong, you're going to get sued, right? If you are that less confident about yourself that you think you're doing something wrong, they pick up on that, you're going to get sexual harassment every single time. You act like a professional EMT like you are, you'll never get sued, right? There might be a conversation where I say, look, ma'am, I hate to tell you this, but I got to cut your clothes because I think you are critically injured somewhere and I got to find it, right? You do EKGs with cables, you have to lift females' breasts to put one of the leads on. Have a conversation. First off, it needs to be somewhat private, you and one other person. What's the other person for? Keep you from getting sued, right? But everyone else, there are 9 firefighters standing around and have no business being in there, right? Have them turn their backs, have them walk away, right? Have a conversation. I'm going to take an EKG, which is a picture of your heart, and I have to touch your breast, right? If it would make you more comfortable, will you lift your breast for me, right? You present yourself like a professional individual, you'll never have any problems. The second you start acting like you're doing something shady, you're going to have problems. Does that make sense? Pretty easy, pretty straightforward. All right, so this is the part that gets really, really thick. Okay, how many of you have reviewed your patient medical or patient trauma sheet? Okay, 2 of you, awesome. So, 3 of you. Sorry, Adam, I forgot about you. So, it's not hard to do. So you work through primary, right? And after you've asked things like sample and OPQRST and all that stuff, every body system has a list of things that you need to assess. Does that make sense? The cardiovascular system, if you think this is a cardiovascular problem, then you need to look at these 4 or 5 things. Or not, there's more than 4 or 5, but you get the point, right? If you think it's a neurological problem, you should assess these 4 or 5 things. You think it's a GI problem, you should assess these 4 or 5 things. One of the reasons why we taught you body systems back in the anatomy and physiology is to lead you to this point right here. So this is the second time you're going to visit it. The third time is in 2 weeks we're going to start going into cardiovascular problems, and we're going to look at just the cardiovascular system and everything that can go wrong with it. Does that make sense? Then respiratory, then all that stuff down the road. Okay? The most important determination when assessing the respiratory system is whether or not your patient is breathing adequately or not. Okay? This is addressed way back under breathing. Right? If you're waiting to get through airway, breathing, circulations, patient priority, vitals, sample, OPQRST, oh, by the way, is my patient breathing adequately? You're going to fail. Okay? This shouldn't even be like a thought in your head because you learned this, on Tuesday with primary assessment. Okay? Number one thing with respiratory is, are they breathing adequately? That's what's going to kill them the fastest. Make sense? All right, so respiratory assessment. Very first thing you want to do is you want to obtain history of the existing problem. Okay? So you walk in the door and say, hi, I'm Sean Pitts. I'm with Deer Park Ambulance. How can I help you? Patient says, I'm having difficulty breathing. Your first set of questions after airway, breathing, circulation, all that good stuff, your first set of questions are about right now, right? Tell me about it. What does it feel like, right? What do you mean by shortness of breath? Shortness of breath means a million different things, right? Are you telling me that you feel like your throat is closing, or are you telling me you feel like there's a ton of bricks sitting on your chest? Does that make sense? There's different variations of shortness of breath. Okay? Now you're going to ask questions about medications. Do you take any medications for this problem? Okay? If they say yes, you say, have you been taking those medications? If somebody ever gives you a med, which 99% of your patients will, one of your questions needs to be, are you taking your medications like you're supposed to be? Does that make sense? Do you have meds? Are you taking them? I would tell you we're not hearing it as much, thankfully, but 5 years ago you would say, do you have any medications? And they go, yep, I got albuterol, I got Atrovent, I got a Duoneb, I got a nebulizer. And I say, okay, have you been taking them? And they say, no. My next question is, how come? And they go, because I can't afford them. It's either medications or it's food. Right? The geriatric population, we heard that all the time. So it's either live on food or buy medications. They couldn't do both. Some of them would buy medications and not eat. Some of them would eat and not buy medications. So are you taking any meds? Or do you have any meds? Are you taking them? If they say no, your next question is why not? Make sense? Now, you're going to ask about previous problems. Have you ever had this problem before? If they say yep, you say, so how does it compare? Is it just like it, or is it nothing like it? Is it kind of like? Does that make sense? And they're open-ended, right? You're not giving them specifics. You're letting them tell you the problem. The more you lead people down the road you want them to, the least accurate information you're going to get. Does that make sense? You're not steering them. They're steering you. Okay? You have to know what questions to ask because, again, remember day one, that whole sheet of your patients don't read your textbook. You read your textbook, so know what questions you have to ask to prompt them to tell you what's going on. Okay, so you've got existing respiratory conditions, you have medications, and then does this match like last time? So here's the physical exam. So all of your patients, this should be in red, I really apologize. All of your patients have a respiratory problem. You're going to assess these things. What is their mental status, which was done back in primary assessment, right? Level of respiratory distress, you start asking questions. Okay, what does it say under chest wall motion? What does that mean? Feel, touch, right? You want to know, is it equal or is it not equal? Is it normal tidal volume or is it shallow or high tidal volume? What does it say under that? Auscultate lung sounds. I will tell you right now that if you don't listen to lung sounds for a patient who has a respiratory problem in this class, you're going to fail. Right? I'm going to require you to wear a watch. I'm going to recommend that you purchase your own stethoscope. Now, I know what you're thinking. How many of you have researched stethoscopes yet? You bought one. How much does yours cost? $35, $40. Yeah. You can get ones from the low end, not that it's not a good stethoscope, $30 to $40 to $200 or $300, $400 stethoscopes, right? If you can afford that, we take donations, okay? If you can't, the $30, $40 stethoscope is just fine for what you're going to do with it, okay? I will encourage you, buy a decent stethoscope. I think you can buy them for $5 or $6. Those are pointless, right? Don't waste your time. That's the ones we give you in this class to use, right? Don't waste your time, okay? If you buy a nice stethoscope, personalize it. Get it engraved, leave it attached to your body at all times, something, because in EMS, that stuff will walk, right? I've had 3 stethoscopes stolen in my 10 years, right? And they don't get stolen by patients, they get stolen by your coworkers. And they just disappear, right? You're like, hey, I left my stethoscope on the table last week. Where's it at? Everyone's like, I don't know. Sure you don't, right? Personalize it, okay? Everyone's got the same color, right? You can go bright pink and someone, yeah, see, you would orange one. At least you can see it, right? At least you're a winner, not a crybaby. Just saying. Stop it. Or a Panther. Or a Cam Newton. All right, pulse ox, right? That should be easy. How do you look for edema? Where are the areas that edema happens? Ankles, hands, lower back. If they're bedridden, the fluid pools in their lower back. Okay? So I just gave, and then fever is the other one. Okay? So if you, in your scenarios, if that person says, I'm having shortness of breath, you have to assess all of these. Right? Mental status should already be done, so you don't have to worry about that one because that should be done back in primary. Right? What's your level of distress? I'm going to palpate your chest. I'm going to listen to your lung sounds. I'm going to get a pulse ox. I'm going to check for edema. I'm going to check for fever. Respiratory is done. Make sense? Heck, that's easy. Let's move on. Let's go to a little more confusing one. Cardiovascular system consists of the heart and the blood vessels. Okay? That's easy. All right, nice thing is some of these are repeated, right, because they're the same throughout these. So cardiovascular, so they say I'm having chest pain. I want to know, do you have existing cardiac problems? Do you take medications? Then I want to know, what's going on with this specific time? The acronym OPQRST was originally designed just for chest pain. Can it be used in every single other one of them? Most of them, right? Anaphylaxis gets to be kind of confusing, right? Because most of these will apply to almost all chief complaints. Make sense? Okay, one of the biggest questions you're going to ask with pain is, I want you to describe to me what you're feeling. If they don't use the word pain, then don't you use the word pain. Make sense? I will tell you, I've seen this happen, and I'm going to talk about OPQRST for just a second. What will happen is the patient will say, I'm having chest discomfort, okay? And I'll go, so what were you doing when this pain came on? And they'll go, I'm not having pain, I'm having chest discomfort. You're like, okay, you're right. Then P stands for palpation, or provoke, right? Which means, does this pain get better or does it get worse? So you're going to say, does your pain get better or worse? And they're going to say, I'm not having any pain, I'm having discomfort. And you're going to say, okay, you're right. Q stands for quality. What does that pain feel like to you? They're going to say, I'm not having pain. See what I'm saying? All of us do it. Paramedics, EMTs, advanced EMTs. They want to put words in patients' mouths. If they say discomfort, then take the word pain out of your vocabulary. Because to them, it's not pain, right? You might say, are you having chest pain? And they might say, no. And you might just say, your next question is, so describe me what you're feeling. They might say, I'm having chest pressure, right? You need to know what their perception is of what they're feeling. Do not put words in their mouth, okay? So here's the physical exam. Look for signs. Look for signs condition may be severe. Look for signs condition may be severe. I don't know what that's supposed to say. Obtain a pulse. Obtain a blood pressure. Okay? Note your pulse pressure. Is there about, what were you saying, Anthony? Between systolic and diastolic? 40. Not good at math either. Spelling and math, not my strong. So I want to be a paramedic. Okay? What's jugular vein distension? Yeah, your neck veins are sticking out. So you're going to look for JVD. Okay? You can use this term as long as you can define it. Because you're always going to go, what is JVD? And you go, JVD, right? Jugular vein distension. Okay? Palpate the chest with chest pain. Okay? What do you think? We're going to talk about differential diagnosis in a second. If someone says chest pain, what is the most life-threatening problem it can be? Heart attack. Number one on your priority list. Now, could it be a pulled muscle? Yes. Could it be pneumonia? Yes. Could it be stress? Yes. Could it be pleuritis? Yes. Just say yes. Costochondritis? Yes. Right? Heartburn? Right? So why are you palpating the chest? They say you're having chest pain. Why would you push on it? Because think about this. Let's say you got kicked in the arm, right, by a horse. I'm going to walk up and you say, I have arm pain. I'm going to push on it. That seems dumb. Why are we pushing on chest pain? So I like that. Does it hurt worse when I push in or hurt when I let go? How far does the pain hurt maybe? I want to know if I push on it, does it make the pain better or worse? Because cardiac chest pain, heart attacks, if I push on it, that should change nothing about your pain, right? Because it's not pain like we think of. It's not a hurt muscle. It's not a broken rib. It's not bruised. It's the fact that the tissue is dying inside your heart, so it's producing pain. Does that make sense? So you push on the chest, and the questions you ask is, does that pain get better when I push, or does that pain change when I push on your chest? The next question you're going to ask is, take a big deep breath. Does that pain change when you breathe? And the third thing is, move your arms. Does that pain change when you move? If the answer is no to all three of them, you just narrowed it down. This is probably a heart attack. If it changes with movement, it's probably muscle. If it changes with palpation, it could be muscle or it could be respiratory. Because pneumonia would change if you push on it. Make sense? So with chest pain, does it hurt when you move, hurt when I push, hurt when you breathe? Make sense? Say again? Usually that's respiratory, right? A big deep breath with pneumonia usually causes that sharp chest pain. Because you're causing that lung tissue to move and it's irritating it. But that shouldn't change your cardiac pain.
Could that also be muscular?
Absolutely. Yeah, with inspiration, expiration just narrows it down. It's probably not cardiac. It can still be cardiac, but it could be either muscle or it can be respiratory. Okay? Observe posturing and breathing, right? Levine sign, because with chest pain, a lot of time comes difficulty breathing, right? Especially MI, but with myocardial infarction, heart attacks, right? Usually shortness of breath and chest pain come hand in hand. Here's the nervous system. Okay, I don't know why mental status is in red. We're going to talk about that more in depth. Nervous system, we're talking about your brain and your spinal cord, right? Medically, we're more concerned about stuff like strokes and brain bleeds. Trauma end, we'll talk about like, broken spinal cords and broken bones and stuff like that. God bless you. With a great EMT instructor. It just happens. Okay? So here's the history. Determine your patient's mental status. How do you do it? Ask them questions. Person, place, time, and event. Right? Then the next one is this normal? If you say what year is it, they say 1948. You look at family and say, is that normal? If they say yes, that's what you got. Right? Alzheimer's, dementia, those patients will give you abnormal answers. Right? So if there's someone there to determine if this is normal or not normal, that's really, really important. Okay? While they're talking, you want to note their speech. Is it slurred or is it clear? Okay? We're going to talk about the stroke scale here in just a second. Okay? We're going to blow over the stroke scale because we're going to re-look at it again when we get into neurological problems, and we're going to teach you a better stroke scale than we've been using in EMS, right? Something new that you guys will be doing that no one else in this city will be doing, right? And then in like 6 months, when you guys are working for an agency, you're going to hear from our lead neurologist who's going to tell all EMS providers to do exactly what you're doing already, right? Because we're changing our stroke assessment. We're finding out it's not good enough, right? It's good stuff. So here's your assessment. You're going to do a stroke scale. How many of you have heard about a stroke scale we use on most of our people? Anybody know? What's it called? The Cincinnati Stroke Scale, right? But what's the acronym? FAST, right? Face, arms, speech, and time. Okay? You should see that. It's on billboards everywhere in Spokane, and it's on commercials, right? The American Heart Association is pushing advertisements and social media stuff for MIs and strokes all over the place now. Speech. Okay? So the stroke scale you're going to do is the Cincinnati Stroke Scale. The best way to remember it is FAST. Face, arms, speech, and time. Okay? With face, what are you asking them to do? Smile. Okay? It's the dumbest thing you've ever asked a sick person who's called 911. Right? Hey, can you smile for me? And they look at you like, are you flipping kidding me right now? And you're like, please? Right? What are you looking for? So go broader than that, though. Symmetrical. Right? They got both sides facial droop. They're just naturally an unhappy person. Right? It should be symmetrical. Okay? The next one is arms. You're going to take their hands, and you're going to say, hey, do me a favor, grab my fingers. I want you to put your hands out in front of you. I want you to let go of my fingers. I want you to turn your palm towards the sky and close your eyes. Right? What you're looking for is an arm drop or an arm droop. Okay? Now with the brain, everything will be on the same side. If it's got right-sided facial droop and right-sided arm droop, they'll go hand in hand. You're not going to get left-sided facial droop and a right-sided arm droop. Okay? It'll be the same side. Make sense? The next one, what?
If we get right-sided facial droop, left side.
You won't. We're going to talk about Bell's palsy in a second. Okay? But you won't. It should never happen. Okay? Speech, what are you asking him to say? Anybody know? It's supposed to be a simple sentence. Yeah, I think that's a show, right? Just kidding. So, you can't teach an old dog new tricks. Old MacDonald had a farm. It's always sunny in Cincinnati, right? I don't care what, it's got to be a simple sentence. Now, what people used to think it was all about the speech. It's actually looking at a couple different places of your brain. If I say, repeat to me, it's sunny in Cincinnati, your brain is receptive and it can regurgitate it clearly, right? You're looking at it, can they hear it? Can they reproduce it and say it back to you? Because there's something called receptive aphasia that allows, I can talk to you all day long, but you just can't say it, right? So stroke patients, it'll be slurred, they can't repeat it or something along those lines. Now the T, which is we've been teaching people throughout the area, to the lay person, we say T stands for time to call 911, right? Do not, in your EMS life, call 911, right? You are 911. Okay, don't be like, someone should call for help. You are the help. Okay? So the time I want you to write down is 3 to 4 hours. Okay? If you get positive face droop, positive arm droop, and slurred speech, you have 3 to 4 hours to get them to an ER for the best chance of that to be reversed. Okay? The downfall with this is it's the last time seen normal. Okay? It's great if this is 5 o'clock in the evening and they saw him an hour ago. This is awesome if they're eating dinner with grandma and grandma drops her fork and they call 911 right away. Where this sucks is this is, 8 in the morning, and what happened is grandson slept in, walks upstairs, and grandma's been wandering around. He walks up and says, "Girl, what's wrong?" And she's got facial droop and speech problems, and you say, "When's the last time you saw her normal?" And he says, 6 o'clock last night. Right? We're outside of that 3 to 4 hours. Okay? Still going to treat them for stroke, but at the hospital, they're outside of the window to be aggressive with what's called TPA. Okay? If you're within 3 to 4 hours in that stroke window, we will fly you by helicopter to a hospital. right? We will drive as fast as I can get to a hospital. Okay? You're outside that 4 hours, you get no helicopter ride, you get no lights and sirens. Okay? Because it's not worth risking our lives driving code to get you to a hospital quickly. Does that make sense? That's huge. That 3 to 4 hour window is awesome. If you can get them to a hospital within 4 hours, the chance of them reversing those side effects, like the face issues, the arm issues, the speech issues, is very high. Outside of 4 hours, it's less likely they'll have no deficits long term.
Like the example you used of the grandson finding how do you judge that it's been more than 4 hours?
Because the last time they were seen normal was 6 p.m., so you have to use that time. Does that make sense?
Yeah.
There's no way to get around that. Does that make sense? That's the downfall. Now, if they're still showing active signs and symptoms, you get on the phone and call Sacred Heart and say, look, here's the deal. Last time seen normal was 6 p.m., but they're still showing positive stroke symptoms. They might tell you bring them code anyways. Because the chances of them still being stroking had it been 6 p.m., pretty unlikely, right? It's probably a pretty new onset. Does that make sense? Adam, go ahead.
Now, even if you do all that, you call in medical control and let them know. Is there a way for, when you get them to the hospital, is there a way or test that helps them determine if it's that window?
No. They just have to go through a couple more hoops before they can give that TPA. If as long as it's still available, they'll do it, right? It's just that statistically, reversible side effects of stroke are within that 3 to 4 hour range for treatment, right? Now, Bell's palsy is the unique one, okay? You know what Bell's palsy is? It's inflammation of the dermatomes in your face or infection of the dermatomes in your face. It presents just like a stroke, okay? Only in the face. It never affects your arms. So Bell's palsy would have face droop, slurred speech, but perfect arms, right? That's typical Bell's palsy, okay? I will tell you that we had an employee here who sits in my office, how long ago, a year ago, 2 years ago, however long it was, who said, I feel funny, and I turned around and looked at him, and he had perfect facial droop, right? This employee is probably in his 60s. Very first thought was he's having a stroke, right? And, of course, I said, whose page is that? Oh, twofer for ice cream today? Dang it, at least you guys can split the cost for 26 people. 27. Technically, don't forget I get ice cream too. I said, go look in the mirror and look at your face. And he walked in the bathroom and said, call Dr. Joel, who works like right next door to us. Right? He's our medical director. He came over, and Joel was like, before you freak out, squeeze my hands. And he squeezed and did a couple other things and was like, you're not having a stroke. I'll bet you it's Bell's palsy. Right? Sure enough. Now, the downfall of Bell's palsy is it could range. Your symptoms could go away in hours. It could go away in days. It could go away in weeks. It could go away in a month. It could go away in 10 years, or you may be stuck with it the rest of your life. There's no way to tell of Bell's palsy, right? So long term, it's scary for those patients, but the good news is you've got to rule out the fact that this is a stroke or is this not. Let her go ahead, and I think you have a question.
Doesn't it go along with like that infection that a lot of the elderly people get that are getting vaccinated? I don't know what it's called.
You think it's shingles? There is a connection, but not always together. Good question.
How many stroke patients do you find in the daytime or they do it in the sleep? Like how many can you really?
I've had a couple of stroke activations. I don't remember like days work, you know what I mean? Like I couldn't tell you statistically. It just depends. I will tell you that hypertension is your biggest red flag, right? Hypertensive patients run a risk for stroke. Your patients that have AFib as a medical history have a high risk of stroke. And then any medication that has a side effect that you like read about, on TV, like, hey, your side effect is massive stroke, death, life-ending diarrhea, all the wonderful like things they name off. Yeah, stop it. Yeah. Don't worry, you no longer have rheumatoid arthritis, but you're probably going to die. Right? That's what sucks. So what else? With neurological, so we got stroke, right? Peripheral sensation and movement. Can you move your fingers? Can you feel your fingers and toes? Make sense? You're going to gently palpate the spine. You're going to rule out trauma. Make sense? Extremity strength. You're going to, are they equal grips or not? Okay? And then you're going to check their pupils. Okay? This is all just for if you think this is a brain problem. Make sense? One of the things that should be on there is you need to check a glucose. Every single one of these patients gets a glucose test. Okay? Hypoglycemic, low glucose patients have an awesome ability to present like stroke, right? Because your brain has to have blood, sugar, and oxygen to survive. You take away sugar and your brain has problems, right? I had a horror story working with the fire department, walk in the door, and they're like, this lady's having a stroke. She had right-sided facial droop, she had right-sided arm droop, she had slurred speech, she had hypertension. We walked in the door and the fire department was like, she's having a stroke. And I was like, great. Called the hospital and said, hey, we're stroke activating. MedStar can't fly, so we're going to drive code, right? We drove code at a very high rate of speed down Division, right? 5 minutes away from the hospital, I was bored, and I was like, we should check her glucose. Checked her glucose, it was 21, right? I went, oops. Gave her glucose, stroke symptoms went away, right? Called the hospital and went, you guys did a really good job. You passed the test. She's not having a stroke. Send your stroke team back up to their floors, right? Because a stroke team is from different floors. They bring down CT, they bring down doctors, they bring nurses, they bring techs, they bring all kinds of people, right? They activate a stroke team. It's like watching ER. There's 15 people waiting for you at her front door, right? And I was like, she's actually just diabetic and her glucose is fine and she actually wants to go home, right? Sorry, good job. You guys did a great job. I feel like a moron. Check their glucose. I will guarantee you in this class, if you don't check a glucose in these patients, I will make sure at the end the scenario is they're diabetic. Even if the beginning part of the scenario they were really having a stroke and you don't check a glucose, at the end I will say their glucose is 20. Right? Or you think they're overdosed or drunk and you never check a glucose, at the end I will say they were actually diabetic. Thank you for calling the cops who put them in a drunk tank who they just died. Right? Diabetic patients present like DUIs. Well, this has happened nationwide. Guy driving on the road, swerving all over the place, law enforcement pulls them over, they're slurring their speech. They got this weird fruity acetone smell like alcohol. The cop doesn't call EMS. They throw them in a drunk tank and they die from hypoglycemia. They seize and die in jail. And then the law enforcement guy gets the crap suit out of them. Right? I will tell you, most are DUIs in Deer Park. Washington State Patrol calls us to check their glucose because they do not want a dead person in the back of their cop car as much as you think they want that. Unless they're shot. Right, true story. Go ahead, Libby. A lot of times, it's just to rule it out. Because I will tell you, the more you transport people, the more, that was the second thing I learned in the EMT class. Everyone lies. And the second one is every time you transport somebody, you educate them for the next time. So what does the DUI guy say who doesn't want to go to jail for DUI? I'm diabetic. And the state trooper's like, of course you are, right? We show up, we're like, glucose is 125, and he goes, great, he's still going to jail, right? We get people all the time. We call it allergy to silver, right? You put them in handcuffs, and they just seize in front of the cop, and the cop's like, are you kidding me? They call us, and we're like, he's not having a seizure. Take him to jail. Yeah, incarcerated. I hate when that happens, right? You just give them a little bit of normazoline, and they just come right out of it, right? Which is normal saline, just pronounced weird. They don't. There are some cops nationwide that are EMT certified, but not here locally. They're not. Even here, if they want to do they want to get a warrant for a blood draw, we still come do the blood draws. Right? So like, let's say an officer wants your blood draw in the field. For one, they have to apply for a warrant, which doesn't take as long as you would think. It's not the movies, right? It takes like minutes because it's an electronic system. The judge is like, yep, do it. We show up, we take their blood, they take the blood, and then transport the blood with them to the hospital or to jail to get it tested. They do. If they're EMT certified, they usually have the equipment. But like here, the SWAT EMTs we have here, they only have trauma medical equipment. They're literally there for like the tactical trauma setting. They're EMT certified, but they don't have all the tools that you guys will have as an EMT. Okay? Endocrine, right? The most common endocrine emergency you're going to come in contact with is diabetes, right? So you just write endocrine diabetic. Okay? Yes, you can have like, hypothyroidism and stuff along those lines. It's not the reason why you're being called. Does that make sense? So if this is their medical history, obviously ask about diabetes, right? Are you taking medications and are you taking them properly? Then you start asking questions. When's the last time you had something to eat? Did you exercise? Have you been sick lately? Okay. Why do we care about an insulin pump? What do you think? Say again? Maybe it's malfunctioning. A lot of times those insulin pumps, when they start to malfunction, it's the reason why these patients' glucoses are in the toilet. Right? They'll be like 21, you'll give them glucose. They'll wake up, and all of a sudden they'll go back to being unconscious again. Right? You ever have any questions, you call medical direction, and they will find a way to teach you how to turn that thing off, to keep them from getting dumped with insulin. Right? Because insulin lowers your glucose, and so what you don't want is just to keep dumping their glucose. You want it to maintain so you can get them to a hospital. Okay? One thing you'll hear me say a lot, hypoglycemia kills you within minutes. Hyperglycemia takes days, weeks. Okay? By far, hypoglycemia, low glucose, is the most dangerous one. Okay? Because that can take 30 minutes and it could kill you. It could take less than an hour. Hyperglycemia, high glucose, can take weeks or days. It's got to create like acid in your bloodstream. It creates sepsis. It's a long-term process that causes a lot of damage. Renal failure, organ failure that leads to death. But it takes days or weeks or possibly a little bit longer. So here's the physical exam. This is the nice thing. Mental status, their skin, glucose. That's really it. Right? This is for endocrine specifically. Okay? I just talked about the neurological side. So if they're having mental status issues, you're going to think this is a neurological problem. Does that make sense? Can you have patients, so we're talking about these individually, can you have patients with more than one problem? Can you have a diabetic who has a heart attack? Absolutely. So fix both problems, right? Can you have a diabetic who's actually having a stroke? Absolutely. Fix both problems, right? Or assess for both problems. Does that make sense? Oh, this is great. So GI, we're talking about the intestinal system, right? You're looking for what goes in, what comes out, and what it looks like when it comes out. What? The poop book? Yeah. What does your poop tell you about you? Yeah. Yeah, there's a whole book about, like, it tells you, yeah. It's great. You should read it sometime. Yeah, it's a bedtime story, actually, by Dr. Seuss. He's real creative with words. Okay, so you're going to ask, what have you been eating, right? Because if they're like, I got abdominal pain, and I've got diarrhea, and you're like, great, so, like, how bad does it hurt? They're like, 8. And you're like, so what does it feel like? They're like, shooting, stabbing pain. You're like, what have you been eating? Well, Taco Bell and Sonic. Okay, problem solved, right? So what's gone in, and then are you having diarrhea? Are you having vomiting, right? You want to know what end are we talking about, right? And then you start asking questions. What color is it, right? Is it dark red or is it bright red, right? If it's coffee grounds or dark and tarry, that's really, really bad, right? If they're puking coffee grounds or it's dark red tarry feces, they're bleeding inside their stomach and it's exiting the body that way. Okay? Those are big questions you start asking. I love patients who puke, right? They're like puking in like a bag, and I say, hey, Anthony, you're my partner. Go look at what the vomit looks like, right? Because you got to look at it, right? Especially overdose patients, right? Patient takes a handful of ibuprofen and then pukes, and it's still in a bag. You start looking for pill fragments. Has it been digested, or did they puke up most of those pill fragments? The nice thing is I won't say take them out and count them and find out if there's any pills missing. Unless we're working together, then maybe I'll be like, start putting them together. Yeah, here's the corner, here's the other. You good at puzzles? Yeah. Is this an olive? When did you have olive? History, oral intake, right? What have you been eating? Are you having any pain? You start asking questions. Any nausea or vomiting? Right? Then you start asking questions. When's the last time you had a bowel movement? Abdominal pain, always you ask questions. When's the last time you had a bowel movement? Make sense? Because if it's been 4 days, that's probably what's causing the pain. Right? Every time. Cheese. You can list those all day long. Now, the way to remember, or a thing to remember, women of childbearing age complaining of abdominal pain is a pregnancy problem until proven otherwise. Okay, I'll say it again. Women of childbearing age complaining of abdominal pain is a pregnancy problem until proven otherwise. Do you know what the most life-threatening pregnancy problem there is? Ectopic pregnancy. So that's like number one, right? That's the egg that's been fertilized in the fallopian tube that doubles, triples, and so on inside and causes the fallopian tube to rupture. The fetus dies, and you bleed to death as mom, right? Unless you're treated pretty quickly. It happens within hours, right? Women of childbearing age with abdominal pain, pregnancy problems proven otherwise. Now, here's the sketchy part. This is where I usually blow people's minds. AHA, American Heart Association, says that childbearing age starts at guess what age? 8. Right? 8 years old. Now, the question that you have to ask these patients, keep the 8 thing in head, think of like 12, 13, 14, so on, right? The question you ask these patients is there any chance you could be pregnant? Right? You're going to ask an 8-year-old in front of dad, any chance you could be pregnant? And what's dad going to do? Knock you out. Right? There had better be a really, really good reason you're asking that question. Like, all signs need to point towards the fact that you think this is a pregnancy problem in an 8-year-old. Right? 12 happens more often than you think. Right? Now, I will tell you, I've been in EMS for 10 years, and I've probably asked that question a lot of female patients with abdominal pain. Right? I have never, so far in my career, had a person answer yes to, is there any chance you could be pregnant? Including people who are pregnant. Right? You're like, any chance you could be pregnant? Nope. You get to the hospital, doctor's like, you're 2 months along. There's no chance. Yes, there is. Right? I can only think of one person that conceived a child with no chance they could be pregnant, and her name was Mary. Right? So ask the question. If they say no, you just move on. Right? You're not going to be like, liar! What good is that going to do?
That's a big
Yeah. Stop it. Can't handle it. Yes, Libby. Oh, just Adam. Just Adam. Move on. Just kidding.
When you ask that,
Mm-hmm.
and I have heard this a couple times, and I want to get your take on it. Are you sexually active?
I usually say, is there any chance you could be pregnant?
But I've heard that. Is that not right?
You can. You can ask that. That's fine. But again, it depends on the audience that you're asking it in front of, whether or not you get a real answer. Right? You ask the 12-year-old in front of mom and dad, any chance you could be pregnant, or any chance, or are you sexually active? The answer is going to be no. Right? Because you have an audience. Right? So those are some questions. And the downfall is if you wait to ask the question, it gets kind of in that shady area. Why are you asking? If you're afraid to ask it in front of mom or dad, then why are you asking the question? Right? I would ask it in the house, and while you're transporting, you'd be like, hey, I just want to confirm there's no chance you're pregnant, right? Like just because you're just rechecking what was said. Does that make sense? So you're asking it twice, but you've changed the audience. And really, does it change anything? If the person says there's no chance I'm pregnant, but you think they're bleeding internally because they're in shock, their skin color's low, their vital signs are low, their blood pressure, you see what I'm saying? You're still going to treat them like they're bleeding internally. So really, does it matter they admitted to being pregnant or not? Absolutely not. It's good to know because it can put on your list. But notice what I said. Any woman of childbearing age complaining of abdominal pain is a pregnancy problem, whether or not they answer that they're sexually active or not. Doesn't matter. Does that make sense? Libby, go ahead. 80. Yep, 8 to 80. World record, I think, is 79. 8 to 80. Now, you might ask, the one question you would ask of that 50, 60, 70-year-old female is, have you gone through menopause? Right? Because that really, again, kind of narrows that down. Because is that a medical question you would want to know of how your body could be reacting? Absolutely. See what I'm saying? There's like sketchy areas, and I will tell you as a male in this job, there are questions you're going to ask that make you feel uncomfortable. Right? When was your last menstrual cycle? Was it normal? Was the flow heavy or not? Right? Those are questions I normally like. I don't ask my wife those questions. And you're going to ask this of a random person you just met. Right? Act professional. There's a reason why you're asking. So if you act like a professional, then they'll portray you as being professional. You act like you're being shady, you're being shady. Right? Not Slim Shady, just shady in general. Stop it. Stand up. Sit down. You are a distraction. All right, physical exam. What position are they in? How many of you ever had abdominal pain? What position is the most comfortable? Yeah, the fetal position, recovery position, right? So observe, if they're like grabbing their stomach and they're curled up, you're like, what seems to be going on today? It's pretty clear, right? I love patients who are breathing like 48 times a minute in a tripod position. You're like, so what's going on? Great story. Assess the abdomen. How are you going to assess it? Palpate, right? Now, I will tell you, we're going to talk about those with abdominal emergencies. You're going to ask them, where in your stomach does it hurt? We talked about quadrants, right? So if they say it hurts down here and they point to that lower left quadrant, which quadrant are you going to push on first? The opposite, right? Work your way to where it hurts. Because if you push on where it hurts first, the entire time you're assessing, all they're thinking about is the fact that you just pushed on the one spot that hurts, right? How many of you have ever been to a doctor, right? I love doctors, you know, like a broken arm, and they're like, let's move it. Does this hurt? Like, it's friggin' the bone's sticking out, right? We are those people. We do that stuff all the time. Oh, you're having abdominal pain? I got to push on it, right? So be careful when you're pushing. Immune system almost always is anaphylaxis. Anaphylaxis is defined as the life-threatening version of an allergic reaction. This is shock. Allergic reaction is hives, itchy skin, watery eyes. Anaphylaxis is your airways closing, your blood pressure sucks, you can't breathe, and you feel like you're going to die. Make sense? One of the drugs you're going to get in this class is epinephrine. Okay? Up until about 2 years ago, we only let you have EpiPens, right? Because that was the safest version of Epi. Now here in Washington State, we have determined that for one, EpiPens are expensive, and they expire before we use them, right? Because they're only good for a year. Now we have multi-dose Epi. EpiPen was about $150 for an agency to buy, one of them. And that EpiPen was 0.3 milligrams for $150. We now have 30 mLs of Epi in a bottle, right? You know how much that costs us? $15, right? So the downfall is you will be learning in this class how to administer an IM injection. IM meaning intermuscular, right? I will tell you that if you give that concentration, if you screw up and give that in a vein, you will kill your patient. It's the one drug that medical directors are scared to death to let EMTs use. And in my opinion, as long as you're trained and you're intelligent, I have no problem with you doing it. You get complacent, you get stupid, you don't pay attention, you're going to hurt somebody. Right? What's that? I am, right? It goes in the muscle. But if you don't draw, you put it in the muscle and then draw back to make sure you don't get blood. The reason why we do muscle and the thigh, or the deltoid and the thigh is because there's a less chance that your veins are usually deeper. Right? But there is a chance that you hit a vein with that IM injection. If you draw back and get blood, you pull that needle out. Because if you give it, it goes right to your heart, and it's a high concentration of epinephrine. Right? And it'll basically make your heart want oxygen so bad that it goes into cardiac arrest. Right? And you'll just kill them. No big deal. It solves all your problems. It's like a tourniquet around the neck solves all your problems. Okay, so, yeah, you're going, bro. So, history of allergies, okay? And when you ask, are you allergic to anything? And they say, yeah, peanuts. You say, what happens when you eat peanuts? Right? Then you ask questions. The number one priority then is your airway. Are you having any tightness in your throat or in your chest? Okay? The reason why this question is up here, medications for a reaction, is we used to only be able to assist them with their own. Right? Us as EMTs, we used to not carry Epi. We used to have to rely on them carrying their own Epi. Right? I will tell you, Washington State has what's called the Kaylee Act. Okay? Kaylee was a 9-year-old girl that was at a friend's house. I think it was in Twisp or one of those places on the west side. At a friend's house who forgot her Epi, and the lady's mom, or the kid's mom, had made brownies with nuts in it by accident. Right? Kaylee eats the brownie, goes into anaphylaxis. EMS shows up and doesn't have Epi. Kaylee dies. Right? So we enacted the Kaylee, I think it was Kaylee or KC, I think it's Kaylee. The KC Act that basically said EMS providers are now required in Washington State to carry our own Epi to administer to patients. That way, in that unique circumstance, they forget it, they don't have it, or whatever, we've got Epi to back them up. Right now, we've gone from EpiPens to multi-dose Epi. Physical exam, you want to look at the point of contact with the allergen. They're stung by a bee, look at it. Okay? Look at their body for hives. Then go back to the airway. You got swollen face, lips, or mouth. Then you're going to listen to lung sounds, because if they start to sound constricted, that's your red flag. Constricted lungs are going to lead to wheezes that are going to lead to stridor that's going to lead to they can't breathe. So that constriction is a good sign to look for to find out what the direction we're going. Make sense? After this, we're going to take a break. We've been hitting this hard for about an hour. Okay? Once you're done writing this down, stand up, take a break. Don't stand up in front of someone who's still writing, which basically means everyone stay seated. Anthony's like, I'm on the end. Blair's the same thing. Can I go? Sit down. Focus. Right, pretend to write so people don't feel bad. Make sense? So look at the skin where they got stung. Look at all the whole body for hives. Face, lips, mouth for swelling. Listen to their lung sounds. The same thing as a tourniquet, right? You got to put the bell of the stethoscope around the carotid artery, though. You got to pinch it between the stethoscope and the neck. Yeah, you got to massage it first. Yeah, true story. I can tell. God bless you. This class is going to be horrible. I can already tell. Can't take you seriously. We good? Stand up, take a break. 10 minutes. Bilateral carotid massage.